So part 2 of antibiotics. The first couple articles, Article 1 and 2 are basically kind of the same study. They just prolonged it, did more patients. We'll just go over Article number 1. This was out of UCLA. Basically, they kind of observed parents coming into a hospital or into a clinic, a bunch of pediatricians, kids 2 to 10 years of age. They all had symptoms of URI. They surveyed the parents. They surveyed the physicians. They also videotaped the interaction. And what they found was that parents expected an antibiotic. They expected to walk out with an antibiotic about 50% of the time. The doctors thought antibiotics were expected by these parents about a third of the time. The doctors thought it was more likely if, one, the parents offered a diagnosis. I think my child has an ear infection. I think my child has sinusitis. And yet they found it really didn't correlate. Those parents that came in with a presumptive diagnosis, I think my kid has this, didn't really expect antibiotics more likely than other parents who didn't come in with a diagnosis. That was interesting. And the parents who were resistant to kind of the non-antibiotic recommendations, the chicken soup kind of recommendations for viruses, again, the doctors thought they were more likely to want antibiotics, but the study showed those parents didn't want antibiotics more than anybody else. So the key is really finding out what's bothering the parents. Article number 2 basically kind of found the same results, and what their conclusion was, find out early what parents are thinking. Find out early on in the discussion. You know, if you find out they think it's a certain disease, they think it's sinusitis, they think it's otitis, as you're examining the kid, talk to the parent and say, these are what my findings are. This leads me to the conclusion your child doesn't have otitis because of these findings, or your child doesn't have sinusitis. So find out early what parents are thinking, and then as part of your dialogue with the parents as you're examining the kid, either be in for or in favor of the diagnosis, what the parents think they have. Article number 3 looked at us as practitioners, pharmacists, nurses. Do we expect or do we get antibiotics more frequently when we bring our kids for health care compared to other populations? This was out of Taiwan. They looked at 50,000 visits of children for colds, URIs, and bronchitises. The antibiotic prescription rate overall for non-medical kids, so kids who were not the children of either healthcare practitioners, was about 44%. For kids of physicians, it was less. It was about 27%. A little bit tick up for pharmacist kids and a little bit tick up for RN kids. But definitely, we're expecting less antibiotics. We're being prescribed less antibiotics compared to our counterpoints of non-healthcare provider colleagues or parents. Article number 4 looks at satisfaction and antibiotic revisits. If you got an antibiotic on your first visit versus I had to bring my kid back for a revisit, he wasn't getting any better. This is article number 4 out of Seattle. 540 kids, they came in for primary care with cold and cough kind of symptoms. They followed up about 70% of them within about 14 days of their original visit. They got antibiotics written for about half of them. Again, you could argue whether or not they needed it. Kids who were not initially written for antibiotics, about 5% of them went back and had another visit and had no antibiotics written. About 8% had another visit, same symptoms, just didn't get any better, and yes, antibiotics were written. When they looked at satisfaction on a scale of 1 to 10, 10 being the best, the kids who had gotten antibiotics on the first visit, their numbers were higher on the satisfaction score for their parents, 9.25 compared to 8.95. Not a huge difference on a 10-point scale, whether or not they got antibiotics. But once you got to the second visit, they had to come back for a second visit. If they got antibiotics on that second visit versus if they didn't, their satisfaction with the first visit went down. Again, I'm not sure what the interpretation of this is, except it seems like we're still not doing a great job probably at telling parents and explaining to them, and we'll get to the next article, explaining the course of most viruses. We say it's going to be better in a few days. Well, in a few days when they're not better, maybe the parents are thinking they need antibiotics. What we really ought to be explaining to them is the real course of viral illnesses, and that's what the next article looks at. Article number 5, or sorry, the article, a couple of articles. The next article, number 5, looks at the time to explain the course of an illness, why we don't need antibiotics, the fact that viruses don't get better with antibiotics, versus I'm just going to write a prescription. A lot of people think it's just easier to write a prescription, right? We think it's faster than sitting down with a parent and explaining to them why you don't need to write one. This is out of Temple University in Philadelphia and another university in South Carolina. Office-based physicians, almost 300 children with URI or bronchitis. Antibiotics were written for about 30% of them. They looked at MD to patient contact time, and they were exactly the same. 14.2 minutes where the antibiotics were written or where the parents actually just got a little bit of education by the physician. There was no difference if the prepaid health plan, no difference if the doc was the patient's primary care physician. What do parents and patients really want to know about their disease? And this is borne out in several studies. The first is, well, what's wrong with me? I've got these symptoms and I need to know if something's serious. What's wrong with me? How long am I going to be ill? Kind of what can I expect over the next few days or the next couple of weeks? What can I do at home? simple things that I can do to make myself feel better. And what do we want them to know? What to come back for. If you develop a fever, come back. If you're vomiting too much, you can't keep POs down, that you would come back for. So there's several things that patients want to know, and there's definitely information that we want to give them, what to return for. Article number 6 looks at this. 300 patients, mean age was 37, 40% were male. They had a lot of family physicians who were part of this study. They came in with sore throat, and when they questioned the patients, like, why did you come here? What were you seeking out of this visit? They had a questionnaire before they left the physician's office. The most important thing for these patients who were coming in for sore throat was knowing the cause. They wanted to know, a lot of people worried about strep throat. Could this be strep throat? They wanted to know the cause in almost 90% of the cases. They wanted to know the likely course. What can I expect to happen in the next few days, the next couple of weeks? The need for pain relief was really high. Obviously, patients come in for pain, whether they're coming in for headache or chest pain or abdominal pain. Pain seems to be a big motivator that gets patients in the ER for a variety of complaints. The big thing that was not really wanted was antibiotics. Only about a third of these patients coming in, their primary reason for coming in was antibiotics. The vast majority of them really wanted to know what's wrong with me and how long do I expect to be ill. Those who really wanted antibiotics, when they looked at that subgroup, they thought pain relief was the big, very high, and they thought antibiotics would make them better faster, and we'll show that's not really true. They thought they were sicker than other patients in the same department who came in for sore throats. They had more faith in antibiotics, and they were less convinced that pharyngitis was self-limited. Article number 7 talks about the usual course of viruses. This is where we don't do a great job. We say, oh, mom, he'll be better in a few days. This looked at children, 290 kids in Britain, 6 months to 12 years of age, about 55 doctors with acute viral symptoms. None of them actually needed antibiotics. They then had the children grade and the parents grade their symptoms over the next 14 days, every day. Both direct respiratory stuff, the amount of snot that you're developing, coughing, and other kind of clinical symptoms. How much was he playing? Was he able to go back to school? That kind of stuff. The mean age was about 5 years. They had been sick for about 3 days prior to being enrolled in this study. About half the kids on day 4, so now we're 7 days into the illness, still had a lot of symptoms. By day 7, so now we're 10 days into the symptoms, about a quarter of the kids still had symptoms. And we tell parents they're going to get better in a few days. And by day 14, plus the original 3 days, day 14, 6% of the kids were still sick. Now, these weren't kids who got better and then sick again. They were sick the entire time. So what this has taught me is to tell parents, I don't care what day you come in on, you're going to be sick for another 2 weeks. That way, if their kid gets better in a shorter period of time, they think they have the golden child. So I think what this is telling us is that we don't do enough telling of parents the real outcomes of these illnesses. You're going to be sick for a long period of time. This is going to take a number of days, if not a couple of weeks, especially if they come in the first couple of days of the illness to get better. Expect this. So don't come back in 3 days or 5 days and saying, my child's not any better. Article number 8 was interesting. They said, what if we call it something different? We don't call it bronchitis. We call it a chest cold. We call it a cold for the same clinical symptoms. Are parents and patients less likely to want antibiotics? And the answer is yes. This is at the University of Chicago, adults in 2 family practice residencies, and they gave them scenarios to read. They gave them clinical symptoms of a patient, kind of mixed up the symptoms in the order of the symptoms in these 3 different scenarios, and then they labeled them different things. They said the physician in this case is calling it a cold. The physician in this case is calling it a viral URI, or the physician in this case is calling it bronchitis. Remember, they're the same clinical symptoms. They mixed them all up. They just called them, labeled them different things. They then said the physician is saying in these 3 scenarios, no antibiotics are needed. So how did this influence the patient's satisfaction or the person looking at these scenarios? They said that patients, it didn't matter what they labeled them, that didn't change their satisfaction. But what they labeled them did influence their satisfaction with treatment. So they said if the patient was labeled as a cold, they were dissatisfied only about 13% of the time if antibiotics were not written for. But if it was called bronchitis, they were dissatisfied almost a quarter of the time, so it went up. So the same clinical symptoms, the doctor said antibiotics are not needed. Solely by labeling it bronchitis, therefore the patient said, you know what, I think I need antibiotics and I'm very unhappy with you. But if you labeled it a cold or a chest cold, I was much happier with your fact that you're telling me I don't need antibiotics. So just calling it something differently, we may get more satisfaction about our patients. Article number 9, sorry, looked at education. And this was a big campaign out in Tennessee with the CDC's kind of support. Over a one-year period, they had a high rate of strep pneumo resistance. So they did this big one-year education over 1996 to 1987. They educated the primary care doctors. They had lectures and guidelines and presentations. They attacked the parents. They had pamphlets at daycares and MD offices, and they dropped leaflets from helicopters. And in the general public, they also had multimedia campaigns, both in kind of texts and magazines and on the TV. And they said, what is our antibiotic prescribing kind of patterns? What do parents want to have seen done in the year before, during this intervention, and the year after it? So the baseline antibiotic prescription rate was a lot higher in this particular county, Knox County of Tennessee, compared to the other counties. But by year 3, they actually saw a decrease in the number of antibiotics that were written for. So education does work, and probably it's a dual component. Parents were asking less for it, and the public and the general practitioners and the physicians that were being educated realized that they didn't need to give antibiotics for a lot of these things. So there was no change in resistance pattern, unfortunately, but it was only a one-year study. So it does show that education actually does work. Article number 10, we'll skip. Article number 11 also looks at patient intervention. These were 30 family practice doctors and 30 patients were interviewed. And basically, they just saw we have a lot of education that still needs to be done. The doctor said, yeah, this was about bronchitis. Yeah, bronchitis is viral, but you know what? A lot of times it could be secondary bacterially infected, and I can't tell the difference. Patients actually had a very vague concept of what infection was all about. Both doctors and patients said cough and difficulty breathing were probably the most important. The patients in these cases who were being treated for bronchitis said they were moderately to severely ill, even though clinical symptoms probably didn't really warrant that, but the patients thought they were really ill. Most of the patients said they would not improve without an MD, and the vast majority of them got an antibiotic written. So we still have a lot of work to do with most of our colleagues, most of ourselves, in regard to patients, in regard to education and the need for antibiotics. What about shared decision making? Having the parent or the patient be involved in, here are the facts about otitis media. Here are the facts about URIs, getting better, not getting better with antibiotics. What do you want to do? You came in here wanting antibiotics. I'm going to give you some education. Let's make a shared kind of decision about whether or not you need them. So this was 466 parents. The kids came in with symptoms of otitis media. They were given information initially saying, you know what, most years get better no matter what you do. You don't have to put antibiotics for every kid with otitis. Then they were given a little vignette to read. And one of them, they were randomized to different vignettes. One of them had a very paternalistic MD in the story, just wrote for antibiotics, didn't really do any education of the family or any kind of shared decision making. And the other two vignettes had some shared decision making. You saw the doctor interacting with the parents and kind of saying, let's come up with a conclusion together. Let's decide this together. In one of the shared decision making, the doctor still wrote for immediate antibiotics. And in the other one, they said, you know what, if the kid doesn't get better in a few days, we'll write you for a prescription then. Well, most of the parents in this study, and again, you have to pick your population where this kind of shared decision-making is going to work. Most of the parents in this study were me, basically. They were well-educated, had good income, insured white mothers. If you have a population that's different than that, it's hard to extrapolate. I work in a population that listens to grandma. Grandma is the be-all and end-all. I can be the physician, I can be a mom and say, you know what, if it was my child, I would not treat your kid's ear infection with antibiotics. Yet they will go home to grandma or the aunt or whoever is the matriarch of the family telling them to get antibiotics, and that's who they're going to believe in my population that I work with. So you have to kind of pick and choose your population where this shared decision-making or some education will work. But I think a lot of us probably practice in an area where you can educate the parents in real time and do some shared decision-making. In the group that wants, so in these parents, after they read the education, they read a little bit of information about antibiotics and otitis. A lot less wanted antibiotics. 14% said they needed antibiotics for otitis media, and before they read the little kind of information, it was about 93%. When they looked who wanted immediate antibiotics, if they read the kind of the vignette where the doctor was really paternalistic and just wrote for antibiotics, they said, probably need antibiotics more. I'll take immediate antibiotics. But for the vignettes where there was more shared decision-making, they said, you know what, I'll wait on the antibiotics. I don't need it right away. And their satisfaction was actually higher. When they had a discussion with the doctor and felt like they were involved in their kids' care and had some decision importance and they felt like they were part of the decision-making process, their satisfaction with the visit went way up. And you guys do that? We can extrapolate this not only to this, but chest pain. I can bring you into the hospital or I can send you home. Here's the risks. Whether or not parents and patients understand that is a separate story, but I think we need to bring more, even like fever workups. A 1-month-old, a 2-month-old that comes in with fever, having parents be part of that decision-making process. I don't think, in the studies that have shown us specifically with fever, if you ask parents what they want to do, they would have you rather do less for their 6-week-old compared to their 18-month-old. It's kind of like, stay away from my 6-week-old with a fever. My 18-month-old, sure, whatever you want. But my little one, don't touch them. And yet, we have the opposite attitude. We do more for the 6-week-old compared to the 18-month-old. Same for chest pain. We're worried about that few percentage of patient population that's going to actually rule in that we need to keep in the hospital to kind of check. Patients, they're much more willing to take a risk with their health compared to what we are. The next few articles look at delayed antibiotics. This is the concept of telling the parent, you know what, most ears get better no matter what you do. Most sinus infections get better no matter what you do. But if you don't get better, let's compromise. I'll give you the script now, or you can come back in a few days, or you can call in, and I'll call in a prescription for you in a few days if you don't get better. Are any of you guys doing that? It's kind of a wait-and-see approach. Are you doing it more now than you did before? I think that's kind of the trend. It can be a little confusing to the parent because you're saying, well, do I need antibiotics or not? If I need them in 3 days, why don't you give them to me now? And the way I spin it is, I don't really think you need antibiotics, but you came in here wanting them, and I want you to be happy. So let's compromise. You try me for a while. Try my tactics. See if it gets better. If it doesn't, we'll go with your plan, and you can be put on antibiotics. Is that a great way of explaining? It seems to work for my patient population. We were just talking about, who was I talking to about the CEO or the administrator that was saying, we don't want you to deliver good quality care for patients. We'd rather have you make patients happy. And that just seems completely against what we want to do in the emergency department. But if we're being pushed by our medical directors and our hospital administrators to have really high satisfaction scores and patients are walking in wanting antibiotics, it's kind of a headbutting. So this is maybe a way kind of to meet in the middle, that delayed antibiotic prescription.
I'll let them go home grumpy, but I won't let them go to another ER. So as they're leaving, they say, okay, I'm going to another ER, I'm getting antibiotics done already.
Yeah. So he was saying if he hears that they're going to go to another ER, then good. And that's the problem. A lot of parents will shop around until they get what they want. And if you can tease that out of them and meet some compromise, try my way for a while. It's going to work. But I'll give you the prescription so you don't have to come back. And a lot of them will show don't end up filling that prescription. 130 patients, this is article number 14, all ages. They were 15 family medicine doctors, all came in with cold symptoms. They were randomized either to immediate antibiotics or wait 3 days and then fill the prescription. Overall antibiotic use over 90% in the immediate group, less than 50% in the delayed group. So again, most of the studies show you do the delayed, much fewer of them will actually fill the prescription and actually take it. Symptom scores, again, no difference for colds, as we know, whether or not you got antibiotics. Baseline, day 3, day 7, day 10, their symptoms were exactly the same. And the satisfaction scores were equal. Whether or not they got immediate, you compromised and gave them a prescription, said try my way first, satisfaction worked really, really well. Article number 16 looked at delayed antibiotics and a little bit of education. This was 81 kids with a clinical diagnosis of otitis media. They got randomized, or they got a 70 course of either amoxicillin or Bactrim. That wasn't really the randomization. What they did was they instructed parents on to really begin treatment only if they didn't improve in about 24 to 48 hours. Some places will say 24 to 48, other places say 48 to 72. 72 hours is kind of the upper limit. If a kid's going to get better with otitis media, they're probably going to do it within about 72 hours. My teaching is if they're still febrile at 72 hours and you haven't started them on antibiotics, yeah, sure, probably start them, but also rethink your diagnosis. Make sure you're not missing something else like a urinary tract infection. So yeah, they probably need to be re-seen and started on something if they haven't been started on it yet, if they're still febrile at 3 days or still having ear pain and symptoms, but also make sure you're correct on the original diagnosis. So the parents got educated about starting the antibiotic later if the patient didn't improve, and then they were randomized to either usual care or they got a fairly good explanation about otitis media, the fact that it gets better without antibiotics, so kind of the course of the symptoms without antibiotics. And most kids will get better. There's complications with giving antibiotics. So one group got educated, another group just got told, wait until they get better. The parents were then called about a week later. Antibiotic use was definitely less in the group that got a little bit of explanation. About half the numbers actually filled the antibiotic. So education does work if you're going to do the delayed. You got to explain to parents why you're not treating initially. Article number 17 was in Pediatrics. This was out of Cincinnati, almost 200 kids up to 12 years of age. Again, looking at this kind of delayed antibiotic. They called it SNAP, the safety net antibiotic prescription. They excluded kids with a fever, though, which is kind of moot, but they excluded kids with a fever, anybody toxic, anybody who'd already been sick for 3 days, they were excluded. They said, okay, we probably should treat those kids. Anybody had a perf, things like that. It really just was ear pain. I think they have an infection. Antibiotics were not filled in about 2/3. Parents were willing to forego antibiotics in the future the vast majority of the time. They were happy with this idea of a delayed antibiotic, and the kids got better no matter what they do. One kid developed mastoiditis. He actually developed it 6 weeks later in the other ear, so it was probably not related to the first episode when they didn't treat the first time. And the development mastoiditis also has been shown not to be really related to the treatment or not treatment. You'd have to treat something like 2,500 kids the first episode or the first day of the otitis media to prevent one kid from developing mastoiditis. And again, the kids that I've seen that come in with mastoiditis aren't telling me, oh, I went to my physician 3 days ago and he didn't treat me. They come in, again, de novo. It's kind of like the peritonsillar abscess. They haven't seen anybody, and they come in with already mastoiditis symptoms. Article 18 basically kind of shows the same thing. 220 kids, amoxicillin versus watchful waiting. They then got about 10-15 minutes of education on otitis media and how it gets better, and we have all this antibiotic resistance. 2/3 of them ended up not using the antibiotics in the watchful waiting group. Their satisfaction scores were no different. Their revisits, their time to go back to work, again, really no difference. When they looked at actually the middle ear, by day 12, there was a little bit trend toward the kids that got antibiotics. Their ears looked a little bit better than the kids that didn't get antibiotics or kind of had the watchful waiting. By about a month, for kids that were greater than 2 years of age, there was no difference. Their ears, and then all the studies show, no matter what you do, the vast majority of kids are going to look good by a month. Few days into it, antibiotics early on may make a middle ear look a little bit better faster, but by a month out, all the ears are awash no matter what you did. For kids at less than 2 years of age, there was a trend, again, for the middle ears to look a little bit better in the kids that got immediate antibiotics, but over half of the kids who had this watchful waiting attitude or was in the watchful waiting group, their ears looked fantastic. So again, the teaching is the vast majority of kids are going to get it better no matter what you do, especially if you wait a few weeks to look at that middle ear. If they're still having a problem, then put them on antibiotics. If they haven't had antibiotics, they should be following with their PMD anyways. Article 19, same thing, otitis media delay in care. They just did this watchful waiting. They actually had the prescription expire in about 3 days. They gave them ibuprofen and analgesic drops. Don't forget to treat their pain. What they come in for at 3 in the morning is pain. And somebody answered this question for me. You walk in the ER, you're working at 3 o'clock in the morning, you see a 3-year-old and it says ear pain. You know what you're going to see, right? A kid in his pajamas holding his ear. You look in the ear, what do you see? A red, bulging eardrum. It's clearly infected. That 3-year-old never has a fever. Never has a fever. And yet the very next chart you pick up is a 1-year-old with a fever. You examine the kid and you're like, well, it's got to be the otitis. How is that possible? I've yet to find a 3, 4, 5-year-old that comes into the ER with otitis media, clearly otitis media. They never have a fever. And yet the littler babies, we always attribute the fever, which is the complaint by the parents, to the otitis media. Explain that one to me. I think we're overcalling otitis media. Again, Article 19, this watchful waiting, antibiotics used a lot less in the wait and see approach. Looking at ear pain, whether or not the resolving of the ear pain, whether they got immediate antibiotics or they had watchful waiting, there was about a half a day difference. Again, your pain might get alleviated a little bit more faster if you put the kid on antibiotics. But if you give the right pain medication, use a little topical anesthetic like Aralgin, make sure they have good doses of Motrin, make sure they have good doses of Tylenol. A lot of parents are giving the same dose as when the kid was 3 months old, and now the kid's 1.5 years old, so make sure they're giving enough. More diarrhea in the group, obviously, that got immediate antibiotics. The next articles really look at parents accepting the diagnosis, or this, not the diagnosis, but this watchful waiting approach. We'll skip to article number 22. Surveyed over 5,000 parents, over almost 300 pediatricians, lots of family medicine doctors in 22 communities. They looked at over 3 previous winters. Half the community got antibiotic, or got a little bit of education about antibiotics. They then got responses from almost half the parents, a little bit more than half of the doctors. The parents were actually satisfied a lot with this kind of watchful waiting approach. About 1/3 of them said, you know what, we'll accept this kind of watchful waiting approach. The more educated the parents were, the more knowledgeable they were about antibiotics, The more concerns they had regarding resistance, the more likely they were to accept this kind of pathway of this watchful waiting. The doctors, they said if they were younger doctors, if they were family medicine doctors, if they had more of a belief in antibiotics and resistance being a real problem, they were more likely to use this kind of watchful waiting approach. So we have a lot of education for ourselves in regard to this. A lot of the last 3 articles really look at, if you're going to give antibiotics, how about shorter courses? Article number 23 looks at urinary tract infections. Unfortunately, they lump babies in with older patients. And the teaching is that if you have a baby with a urinary tract infection, until proven otherwise, it's really considered upper tract disease. It's really pyelonephritis in an infant. If you have a teenager and they just come in with urinary symptoms, it's more likely probably just a cystitis unless they have real clinical symptoms of pyelonephritis. In these studies, unfortunately, they lumped littler babies, probably upper tract disease, probably needing longer courses, with older patients that we know clearly have more likely lower tract disease and can have shorter courses. So this was urinary tract infections in Sweden, almost 300 kids who were less than a year of age up to almost 16 years of age with first urinary tract infections. They got 5 days of a variety of different antibiotics and really showed no difference in their outcome. At follow-up 3 to 5 days, 4% of the girls and 2% of the boys had persistent symptoms, but negative culture. So just because the kid's still having dysuria in a couple of days doesn't mean they're always going to have a positive urine culture. At 4 to 6 weeks, only 1% of the girls and 0% of the boys actually ended up having a positive culture. So short courses seemed to work. Again, they were lumping bigger kids with smaller kids. Recurrent urinary tract infections, about 2% of the girls ended up developing a new infection about a month later. And those were kids that had obviously been treated. Article number 24 is in Pediatrics. Again, they lumped newborns with 18-year-olds. These were meta-analyses of 17 randomized controlled trials, short courses compared to long courses of antibiotics. Again, lumping a newborn with an 18-year-old, they're completely different animals. There was 1,100 patients. They defined what a treatment failure was. They defined what a reinfection was. And 7 of the 9 studies basically said there was no difference, statistical difference using short courses compared to long courses. They looked at treatment failures, they looked at reinfection rates. And the last article is number 25 that looks at high-dose azithromycin for a variety of illnesses, both otitis, they looked at bronchitis in adults, and they looked at tonsillitis in adults. And they said comparing it to 3 days or 5 days of azithro, if you gave a whopping big dose. For the otitis, it was 30 milligrams per kilo for a child, big dose. Of course, there was no placebo arm, but at least it worked compared to 3 days and 5 days of azithro, and I think it was also a single dose of ceftriaxone was compared to. 2 studies looking at high dose 1.5 grams, that'll make you vomit. For community-acquired pneumonia in adults, a kind of a one-time dose, same efficacy as 5 days of azithro, same efficacy as 10 days chlorothro. And 1 study looking at 1.5 grams of azithro also for adult tonsillitis. Again, really no difference when you compare to longer courses of your typical antibiotic. Article 26 looked at group A beta-hemolytic strep, kind of standard therapy of penicillin compared to the cephalosporins. Long courses, the bottom line is long courses or short courses of the cephalosporin were equal. So if you're going to choose a cephalosporin for a group A beta-hemolytic strep, what you think is pharyngitis is group A beta-hemolytic strep, go ahead with a short course. And again, like we saw in some other studies, but if you're going to use penicillin, you got to use a longer course. There were definitely some treatment failures in kids that only got a short course, 5 days, 3 days of penicillin. You just didn't get good bacterial eradication. So if you're going to use penicillin, you got to use a longer course. Side effects seem to favor the shorter courses. Compliance seemed to favor the shorter courses. And it's probably that's actually I think the last article wouldn't do. Any questions? Seems like you guys are doing more and more of the delayed antibiotics, which is probably a good thing. It makes your CEO happy because your patient satisfaction scores will be up. It's just a little bit difficult to kind of explain to the parent why. And what I do, like I said, is this is what I believe in, but I want to make you happy. Let's compromise. Do my way first, and then we'll do your way. Do you have a question? Sorry? For sore throat? Good old Motrin, and if it's really bad, Decadron. How many of you guys are using like a 1 course of Decadron? When I was at early college, I had bad mono, and I got 1 course of Decadron, and I remember this 20 years later. It was like a panacea. Have you guys had steroids for a sore throat? The head-to-head study seems to like it works, and I think most of us are kind of doing it. So any other tricks that people are doing? The sprays, I don't think they work all that, and they taste terrible. They're nasty, so. Yeah, put them to sleep a little bit. Yep. Yep. Make sure they're using enough of the Motrin. Make sure they're using enough of the Tylenol because they're using the same dose. The kid's 5 years old. They're using the same dose as when they were 1-year-old. So make sure that you've weighed the kids in kilos, make sure they're using the right amount of medication. Thanks, guys.